going to move this away from the microphone, so watch that.
Good morning. Thank you for the opportunity to present the HOPE study. I'd also like to acknowledge two of the co-authors here, Jen Ligabell from Dana-Farber and Brenda Cartmel from Yale. So while aromatase inhibitors are standard of care for hormone receptor-positive breast cancer, side effects have resulted in poor adherence and drug discontinuation. We know that discontinuation rates of 20% within the first year of AI use have been reported, and that there are reports of up to 40% of patients not taking the medication daily, and that poor adherence and discontinuation has been independently associated with mortality. Arthralgia is the most common reason for drug discontinuation and poor adherence to AIs, and is defined as a pain or stiffness in the joints, and is reported in up to 50% of patients within 6 months of initiating therapy. Women report having aged abruptly, and that this pain may be signs or fear of recurrence. So exercise may be an especially attractive strategy to improve AI side effects as well as quality of life, and perhaps adherence to AI therapy, as well as overall survival. So the HOPE study, funded by NCI, was a randomized trial to examine in 121 women who'd been taking an AI for at least 6 months and experiencing at least mild arthralgia, measured from the brief pain inventory and a score of at least a 3. The year-long effect of exercise versus usual care on side effects. For today's talk, I'm focusing on the severity of arthralgia. So to be eligible, women were postmenopausal stage 1 to 3 breast cancer, hormone receptor positive, and taking an AI for at least 6 months, and currently experiencing at least mild arthralgia. We did block on whether they had joint pain before initiating AI therapy, and then when we screened them, if the AI exacerbated this joint pain, they were eligible for the study. They were able to exercise, but not currently in an exercise program or exercising more than 90 minutes per week. So arthralgia is the primary measure of, the brief pain inventory is the primary measure of arthralgia, and this was a questionnaire developed in cancer patients, and there's 3 items looked at: worst pain, pain severity, which is a measure of your worst pain, your least pain, pain now, and average pain, and then pain interference, which is related to 8 activities or traits. And it's reported on a scale of 0 to 10 with mild, moderate, and severe pain. There's strong reliability with this questionnaire. So women were randomized to either a year-long exercise program, which was twice weekly supervised strength training sessions, or 2.5 hours per week of moderate intensity aerobic exercise, such as treadmill walking. This is the current physical activity recommendation for healthy adults as well as cancer survivors. Women randomized to usual care were provided written information on the benefits of physical activity as well as the recommended amount. Both groups of women had AI adherence assessed each month. So the results at baseline, women were on average 60 years old, mostly non-Hispanic, white, and highly educated, physically inactive and overweight, mostly stage 1 and 2, and about 2 years post-diagnosis, so had been taking an AI for about a year and a half. There were no baseline differences between the 2 groups at baseline. So what happened over the course of the year? Women randomized to exercise increased their exercise 159 minutes per week on average, which slightly exceeds the recommended amount. And the usual care women increased their exercise a little bit, which is common in a randomized trial. When you're enrolling people into an exercise program, even if randomized to usual care, they might increase their exercise a bit. Attendance to the twice weekly strength training sessions was 70%, and there was about a 7% increase in cardiorespiratory fitness, which is an objective measure of physical activity, implying that the women did adhere to this exercise program. Change in body weight was on average 3% among exercisers, and no change in usual care. So at baseline, when we look at the BPI scores, we see women had a score of worst pain around 6, putting it in a moderate pain category. There were no differences between the 2 groups. And over 12 months, we see among the controls a slight increase in joint pain over the year, compared to exercisers who saw about a 30% decrease in worst pain and about a 20% decrease in pain severity and pain interference. And then over the course of the year, we see that it is probably a year-long exercise program that's important to see the sustainability of decreases in joint pain rather than maybe shorter durations of exercise of 3 or 6 months. We did also observe a dose-response effect with those who are more adherent, 80% or more adherent to the exercise program, having better improvements in joint pain. However, even those who were less adherent still had about a 15% to 20% improvement in joint pain. So potential mechanisms include that increased muscular strength. Strength may lead to resistance to injury, improved aerobic conditioning, leading to improved blood flow and maximal oxygen consumption. Improved range of motion and weight and body fat loss could be a mechanism. It did not modify the effect in that those who lost weight did not have greater improvements in joint pain. Decreased systemic inflammation levels also may be a mechanism. We did collect fasting bloods at baseline and 12 months on these women that we will in the future analyze to see if it is a potential mechanism. An improvement in pain threshold, making activities of daily living easier to perform and therefore less pain. Strengths of this study are that this is the first study to examine the effect of exercise on AI side effects using a randomized design and a year-long trial with valid and reliable measures and a transdisciplinary team of scientists. The limitation is that we don't know if it's primarily aerobic exercise or resistance exercise or are both necessary to improve this common side effect of AIs. So at enrollment to our trial, about 2 years after diagnosis, we saw that women reporting moderate joint pain and that a year-long exercise program reduced pain by about 30%. And this improvement in pain has been shown to be better than other therapies for arthralgia, such as glucosamine, vitamin D, and acupuncture. So in conclusion, our findings of exercise improving a common AI side effect may in turn improve AI adherence, quality of life, and breast cancer recurrence and mortality risk. Thank you.
Questions then?
Nick Mulcahy from Medscape. Just out of curiosity, has there ever been a study of exercise and just regular old joint pain?
Yeah, that was sort of the literature we reviewed in writing this grant application, showing that exercise is beneficial in rheumatoid arthritis, osteoarthritis, and fibromyalgia, and therefore it might be beneficial in women taking AIs. So it is correct what Dr. Kuzik said. A lot of women taking this medication do report pain probably before starting it, but it does exacerbate it. And if exercise can help, in turn, in helping adherence to the medication, then I think that's important. But yes, it has been, exercise has been shown to be beneficial in other populations with joint pain.
Bruce Jansen, Oncology Report. 80% adherence over the course of a year in a previously sedentary population. Boy, that sounds really good. How'd you do that?
Yeah, so it helps to have a personal trainer. It helps to have the gym membership paid for. So, you know, they did meet twice a week with a trainer. It was small groups but individualized attention. I think having the small groups, the women really bonded with each other, and in fact, a lot of them are continuing to meet at the gym at similar times and exercise together. But there are now growing numbers of programs that are offered across the country and perhaps the world where there are free programs to initiate exercise programs for cancer survivors to give them that start, and then they have to continue on their own.
Is it your impression, I know you work with cancer patients primarily, but is it your impression that they're a more motivated group than sedentary people without cancer?
I do think so. I think that after they finish their initial treatment, and even if they're continuing to take endocrine therapy, they still have this fear of recurrence and mortality. They're not seeing their clinicians as often. So in this study, could be too, the attention with a trainer helps improving some other side effects. But I definitely think they're a little bit of a more motivated group and more aware of their health.
There seems to be
Alice? Me first.
Okay.
Come on. Huh. Wait your turn. Michael Smith, MedPage Today. I'm a bit puzzled. This, in one sense, this seems to be a no-brainer. Exercise is good for what ails you, and we know that. And so I took it that your goal is to see if exercise improves adherence to the aromatase inhibitor. And I didn't see any data on that. Do you have data on that? Do you know if these people kept taking their pills?
So for your first question, it is a no-brainer, yet 70% or more are inactive, and that's healthy people and cancer survivors. So the more research findings we have showing the benefits of exercise will hopefully inform clinicians to refer patients to exercise programs and to remind patients to exercise and the benefits of it. Number two, when we proposed this trial, it was to focus on those taking the medication and how to improve side effects. So we knew that these women had been taking it for at least 6 months because so many do stop taking it within 6 months or a year. So they had to be taking it for at least 6 months. So we knew that few would stop during the duration of the trial. Only 5 women actually stopped taking AIs of the 121 enrolled. And so we were really interested in looking at pain severity. Hopefully our next study will be to look at a lifestyle and exercise and or weight loss at initiating aromatase inhibitors to look at adherence directly.
So just to follow up, the initial sort of rationale that you talked about, that people stop because they have arthralgia, joint pain, really is not addressed in this study.
No, we were looking at treatment of side effects.
Thank you.
Not prevention.
Okay, Alice Goodman with the ASCO Post. I don't know if you're aware of it, but there's an NCI-sponsored study on breast cancer survivors using exercise for joint pain because of a pilot study I heard at the American College of Rheumatology in breast cancer survivors on AIs who participated in an exercise program developed for people with arthritis, but given to these breast cancer survivors, and it improved adherence and pain and all that other stuff. But there seems to be a dissonance between what you said and what the speaker who talked about, he left,
Dr.
the
Cusick.
first study, the HOPE study, where he sort of made light of these side effects. And arthralgias, women really complain about this when they're on these drugs, and your study acknowledges that up front, and I don't know what to make of that.
So I think he wasn't making light of the fact that women do report joint pain. I think he was implying that it's common among postmenopausal women whether they're taking AIs or not. And we did find in screening these women that, you know, a third did report joint pain before starting the AI, but that even among those third, the AI exacerbated symptoms. And then the other 2/3 of women didn't necessarily have joint pain at all before starting the therapy and then developed pain afterwards. So I think that's the point. I'm not aware of the NCI-funded study unless you're talking about my study.
All right, then further questions? Okay, then Dr. Arteaga, I believe we're ready for the next speaker. Oh, wait, in the back row. Kate, wait for the mic, please.
I'm wondering how many clinicians are already prescribing exercise for breast cancers, people who are in treatment or survivors?
That's a great question. Maybe Jen Ligabell, as a medical oncologist at Dana-Farber, I know that she recommends it regularly to her patients, but if you could provide a comment on what you think your peers, if they're recommending exercise.
Jen, just remember as you're stepping to the podium to state your full name, title, and any financial disclosures.
Sure. I'm Jennifer Ligabell. I am an assistant professor of medicine at Harvard Medical School and a senior physician at Dana-Farber, and I have no disclosures. So I think that for a long time we've known that exercise is beneficial for many things in cancer survivors, yet there aren't many programs that people can be referred to, and I think also that there has been a little bit of a lack of knowing that this is better for cancer survivors than everyone. We all know we should exercise, but I don't think this is something that most medical oncologists in the past have really focused on. I think that's changing as there are more and more studies like Dr. Irwin's where we see specific benefits of exercise in cancer survivors, but the overall prevalence of exercise in breast cancer survivors is not really changing. So we really need to figure out how do we help people exercise more, and how do we put in place programs that can help women on a large scale become more active after cancer diagnosis.
Michael Smith, MedPage Today. I'll just ask one more quick question, if I may. I have a family experience with an AI, and the joint pain tended to fade after 6 months. And I'm told that the joint pain is much more severe in the early period of treatment. How do you distinguish, because your exercise program starts at 6 months, how do you distinguish between the natural fading of these symptoms and results from exercise?
So that is correct. There is some published literature showing that women, when they start the AI, might have symptoms and they fade maybe after 2 months of being on the medication. And that's why it's important to maybe keep them on the medication for at least a full year, because symptoms could change. But that's why we really spent a good long time on the screening for this study. So women had to be on the medication for at least 6 months, knowing that some symptoms would dissipate within 6 months, and they had to have at least mild pain on the BPI scale. So if they just had a little bit of pain and it wasn't that much of a problem, they weren't eligible. So we did enroll a group that pretty much had pain due to the AI. Thank you.
I'm sorry, I just had a quick one. Did the comparison group get access to the gym as well, if they wanted it? And
yeah, so the standard of care is that we give them information on the benefits of exercise and the recommended level. So at the end of the trial, they did have an opportunity to meet with the trainer and come to the gym for 3 sessions to give them a personalized exercise program.
sorry, I meant they did not have free access to the gym during the trial if they wanted to be self-starters.
No, because that's not standard of care.
Thank you.